So good evening, all the students present here. So today topic is endocrine disorder, and the faculty that we have here is Fathy Elshazly sir. So you may take over. Thank you.
Thank you so much. Um, Good evening, everyone, wherever you are. I know it might be too late now. I'm very sorry for that, but it's still in the afternoon here in England. So, our topic today will be about endocrinology. Endocrinology usually it's comes in every exam, but usually when they bring endocrinology cases, they either bring them on the CBS, either in the form of CBS case-based scenarios to identify where is the problem from the chemistry, or if they bring it in the CCS, they usually bring it either a short case or a vignette of a long case. A vignette means that it's a portion of the long question, either the admission diagnosis or sequelae of prolonged stay in ICU or the therapy which is being given while they are in or on the ICU. So actually, I thought since I was asked to prepare this lecture, what is the best way to deliver this session to make it useful and at the same time take as much information out of it, and most important, not to make it boring, because endocrinology is a very, very boring subject. Uh, so instead of doing long case, like we did in the other previous sessions, we are going to just do a short cases so that we can see a lot of examples, and you can gather as much information as we can. And as I'm always mentioning, those kind of sessions without your participation are useless. So please just try to participate as much as you can to get the benefit out of it, and not to get bored easily, because you might get bored easily out of this session. And I hope that the way I designed the session wouldn't make that boring for you. So the first case, as always, I'm going to ask a volunteer to just you can hear my voice and you can see my screen, right? Any answer, please? Can you hear my
Yes,
voice?
we are hearing you very well, and
And you can see the screen. Okay. Okay,
Yeah.
thank you. Okay. Because actually I'm struggling. I don't know why it's happening now. Okay. Okay. So I cannot see the participants for some reason, but anyone can read the question, please, for us. Any volunteer?
Okay, let me
Okay.
read.
Okay, thank you, Dr.
Okay.
John.
Yeah. 54-year-old man who has been admitted to intensive care with a community-acquired pneumonia and septic shock. He has a history of insulin-dependent diabetes mellitus and depression. He is currently ventilated and receiving vasopressors and renal replacement therapy. After 10 hours of aggressive hemofiltration, he continues to have a refractory metabolic acidosis. What are the main differential diagnoses of persistent acidosis, and what further investigations would you request? We have, I think, the lab results. Should I go ahead and read out?
No, it's okay. Just read
Okay.
them. Just read them without letting us know. But
Okay.
I because it's from an English book, so I brought the units in milligram per deciliter, and regarding the creatinine and urea, and then regarding the BO2 and BCO2 from kilopascal to millimeter mercury, so that if you are not used to those kind of units. So when you are ready, just let me know, please, Dr. John.
Okay.
Okay. Any differential diagnosis in your mind at the moment? Usually in the exam, have 5 minutes to go through the vignette, but we just will try to shorten it a little bit now. I'm sorry for that, but I know it's a long case, but any differential diagnosis in your mind?
Okay, the main differential diagnosis I'll quickly think of right now is one, there is still uremia despite the ongoing renal replacement therapy. And although I didn't see the ketones, but I think it's also possible that he has some decayed diabetic ketoacidosis. It's a possibility, even though there's no result for ketones here.
Great. Great. Okay, what else?
So even chloride is not available. I would like
Sorry?
to chloride values are not available, and
Very
then
good. Yes,
because
exactly.
it's insulin dependent diabetes mellitus, I would like to calculate the anion gap, and albumin might be useful. Oh, we've got the albumin here, which is low, which will help in calculating the high anion gap acidosis. And because I'm not sure if the patient has been fed as well, so there could be possibilities that the patient might have some kind of starvation ketoacidosis as well. Obviously, urine and the serum ketones would definitely help with that.
Lactates are also high, sir. Lactic acidosis.
Yes, so it might be hyperfusion, right?
Acidosis may be septic due to septic shock, and maybe drug overdose as patient is on treatment of depression.
Okay, that's good. That's great. That's what we need in the exam, that we always need differential diagnosis. Even if you got the right diagnosis from the first time, they usually appreciate that you always have a broad mind, that you always look for differential diagnosis, other possibilities. Okay. So, and they are going to ask you always, what else, what else, what else, even if you got the right diagnosis from the first one, they are going to always to ask you what else, what else. So don't be offended or pressurized by that. It's normal. It's part of the exam because they want you to give the full mark. So they are going to keep asking you what else, what else, what else. Okay. So this very good differential diagnosis actually from all of you. So as you all mentioned, hyperfusion would be the first thing we are going to look for, especially in the presence of high lactate. We would like to check the cardiac output via the minimal invasive methods like PECO or via the echo or whatever the cardiac output you have way you can get. Sometimes I know it's out of date now, but some people still depends on the venous saturation, although it is not recommended anymore. But you have to check for the perfusion and of course clinically whether the patient is hyperfused or not. You might be an ongoing acute kidney injury that you might and the filtration is not correcting it, and so you have to change your filtration settings in order to tackle that. Can be diabetic ketoacidosis as mentioned by John. It can be hyperchloremic acidosis as well, which was mentioned by you, and that's why you need the chloride level. Can be unmeasured anions and can be due to drug toxicity as well. And that's why it's always usually in any case, whether chemistry or anything which is discussing biochemistry of the body, usually the answer in the anion gap, osmolar gap, and sodium homeostasis. Most of the cases are about those three things actually regarding when you are talking about any endocrinological or chemical disturbance or derangements on